Welcome to the Ventra Health webinar series. Let's give everyone a little bit of time to join us and then we'll get started. We'll be back in a couple of minutes and then we will begin. Welcome everyone. My name is Heather Allen with Ventra Health's Marketing Department. Thank you for attending our webinar on the 2023 Evaluation and Management Guidelines presented by Angela Jordan with Advisory Solutions. This webinar does have AAPC, CEUs, and other, and they will be sent along with the presentation and handouts after this via email after the webinar. If you don't receive these or have trouble downloading them, please contact us and we will assist you. As time allows, Angela will answer some questions that we receive in the chat. We will send the questions and the answers to all attendees. Your microphones will be muted. However, we ask that you keep your cell phone silent at this time as the session is being recorded. Finally, thank you again for attending the webinar. Now I will hand it over to Angela.
Thank you so much, Heather. And I want to welcome everyone joining us today. We know you're busy and taking time out for this type of education is valuable. We are really excited because the 2023 E&M guidelines round out the historic changes that actually started with the release of the 2021 Office and Other Evaluation and Management Guidelines. We'll get the disclaimer out of the way. This presentation is based upon my interpretation and is made in good faith with the information available at this time it was prepared. This presentation is not intended to constitute and or substitute for legal advice. CPT is the authoritative resource, and any references to codes in this is not replacing the information from the CPT book. So for today, what we're going to focus on is a high-level review of the 2023 Evaluation and Management Guidelines. I'm going to identify the revisions, some of the revisions in each category, review the requirements for choosing an E&M level, and identify right now the available resources. Hopefully, this will also provide you with the ability to actually understand some of the documentation requirements. So let's get started. Right now, we're going to go out with the old and in with the new. As of today, we're working with actually 3 sets of guidelines. We have the ones that came out in 1995. Then we have the guidelines that came out in 1997 that were meant to help specialty providers with the uniqueness of their specialties, which provided them the ability to get the higher levels of service using a special examination elements. Then in 2021 is when they started to change things up, where they removed the elements of history and exam from leveling and went straight to medical decision making. So now what we've done come January 1st is we're going to get rid of all 3 sets, and we'll have the brand new evaluation and management service guidelines that basically combine everything. So we won't be referring to 2021 E&M any longer. It'll just be the new evaluation and management guidelines. So what they've done is they've revised the guidelines for hospital inpatient observation, consults, emergency nursing facility, and home and residence codes. And in the process, they ended up deleting things that really were already being combined, or the guidelines were really in place for. So they got rid of the hospital observation codes. They deleted the lowest level consult codes. Then when it came to the nursing facility, they just deleted one code, the 99318. Then domiciliary, rest home, and custodial care, they actually ended up merging them, and we'll talk about that later. So they deleted them and they merged them in with another group of codes. Then home residence, they deleted one code. And then prolonged services, what you're going to see is they have deleted the direct face-to-face code, because the way they have revised the other guidelines, the direct prolonged service codes no longer make sense because of the way they've redone that code, and they've developed a brand new code. So basically, to start off, what has happened is providers still need to document a history and exam. It's still extremely important. That history really starts the story of why the provider is seeing the patient. Now, in the hospital or, in the residence or the facility setting, a lot of times that patient is already there. They've had that initial visit, but those subsequent visits are just important. And the history will still need to dictate why is the provider seeing the patient today? Why is it medically necessary? So the guidelines are no longer going to dictate the level of documentation or the level of history that needs to be there. It just needs to be medically appropriate. And so therefore, the history and exam, the nature and extent is going to be determined by that treating provider, whether it be a physician, whether it be a nurse practitioner, whether it be a podiatrist. It's got to, the history and the exam are going to be dictated by the provider. In the guidelines, they solidified that the care team can collect that information. So the care team can see the patient, they can document, the physician can refer to it. The same thing with the patient or the caregiver. They can clearly, nowadays with EHRs, with patient portals, questionnaires they send patients prior to the appointments, all of that information can be completed by the patient or the caregiver. It just has to be reviewed by the provider so that it is appropriate and they, reviewed it and agreed with it, and it's part of the record. Again, the history and exam is not going to be used to level the service. However, we're going to go to medical decision-making or time. So what's the difference? Well, medical decision-making, what the AMA has done is taken the CMS table of risk, and for lack of a better word, they have beefed it up. They wanted to keep a format that was familiar to us, like they did with the evaluation management when they started the changes in 2021. They really wanted to keep something that was familiar. So now what they've done is they've taken the medical decision-making table, and right now you're going to use the number and complexity of problems that are addressed during the encounter. Then you're going to have a column for data, which is data that is reviewed and analyzed at on the date of the encounter. And then lastly, you've got the risk of complications of morbidity and mortality of patient management. So what we're working with right now is that if it's a new patient, it has to be 3 of 3 components. If it's an established patient, it's 2 of 3 components. Likewise in the hospital. If it's an initial admit, it's 3 of 3. If it's a subsequent visits, it's 2 of 3. Now, going forward in 2023, every level of service is 2 of 3. It doesn't make a difference if it's a new or established patient. It doesn't make a difference if it's, a new initial or subsequent visit. Medical decision making is always going to be 2 of 3. The other component we have now is time. And time is going to be the total time on the date of the encounter. So they are going to value now all of the time the provider takes once they step out of that patient's hospital room or once they step outside of the patient's, nursing facility room, because your work doesn't stop when you stop seeing the patient. There's still coordination of care. There's still things that you are doing. With that being said, no longer is there that requirement in order to bill on time that greater than 50% of the service has to be in counseling and coordination of care. That component is gone. So now it is literally the total time on the data encounter. This is time spent both to face-to-face and non-face-to-face services. And we're going to talk about time first because it really is more straightforward than medical decision making. So what we're going to start off with split or shared service. Now, when the AMA talks about split and shared services in the evaluation and management guidelines, it's completely different than split or shared services to Medicare. Because in Medicare, split shared service is actually revenue based. There are specific rules for split shared that you have to follow, and there's a modifier that you have to use. But when the AMA talks about split and shared services, for their purposes, it's when 2 or more providers, that is a physician and a non-physician practitioner, jointly are seeing a patient together. When the 2 of them are together, either with the patient directly in the room, or it might be outside of the room when they're discussing the patient, only one of those providers can count that time. It cannot be duplicated. So if a physician and a non-physician practitioner, let's say they spend 10 minutes outside of the room, the physician that is going to maybe bill or count that time, and let's just say in this scenario, it's the physician gets to count the 10 minutes that they were together, not the non-physician practitioner. And likewise, there are the time that can be counted. Here are all the bullets. So in other words, the physician is getting ready to see the patient, and let me remind you, this is only on the date of the encounter. So he's preparing to see the patient. He might be looking back, reviewing tests. He could be looking at information that came through the patient portal and reviewing it. It could be that face-to-face visit, so that exam, counseling and counseling and educating the patient, or possibly the caregiver that's there with the patient, any orders the provider does. And it could be procedures, it could be working with someone there that is going to try to schedule a test for the patient, referring communication with other healthcare professionals, documenting in the EHR, that is time, independently reviewing results, care coordination. Now, if the provider is going to bill for any of these services, then the time spent in doing that would have to be separately reported. So they would have to carve out similar what they would have to do if they were billing critical care and they provided a billable service. They would have to have a statement in their documentation that this time excludes separately performed procedures. Then there are things that they cannot count the time for. Again, like I just stated, separately billable services that they're going to put on the claim. They cannot count any travel time, and that's going to come into play with the home resident services and even the nursing facility if they're traveling. Any teaching that is general and not limited specifically to the management of a patient, that comes into play in the teaching setting. So now let's jump right into medical decision making. So we still have 4 levels of medical decision making. The first one is straightforward, and as you can see, we have the 3 columns that are on the CMS table of risk. The first column is number and complexity of problems addressed at the encounter. And they added the word addressed because this also flows into the guidelines for diagnosis. And then basically what the AMA has done has mirrored the MEAT, which is during the visit, did you manage, evaluate, assess, or treat a diagnosis? So our first column for straightforward is one self-limited or minor problem. When it comes to data, it really stayed the same, minimal or none. Then when you get to the table of risk, you'll see that the examples are now gone. The AMA said that risk is some of the things that were in the minimal and low, depending upon the patient's condition and the status. They didn't want to put examples in here any longer because there were times that when maybe something in one of those areas based upon like possibly an interaction or something like that could actually pose a higher risk. So you'll see they've removed the examples for risk. Now it's 2 of 3. You don't have to have all of 3 of these to get straightforward. It's 2 of these 3 columns. Now let's look at the number and complexity of problems addressed at the encounter. So the AMA is stating that comorbidities and underlying diseases in and of themselves are not considered in selecting a level of E&M service unless they are addressed, and their presence actually increases the amount and or complexity of data to be reviewed and analyzed, or it really increases the risk of complications of morbidity and mortality to the patient. So what they're doing is they're mirroring what is going on with diagnosis coding. You only report diagnoses on your claim that you've actually managed, evaluated, assessed, or treated during the encounter. Simply stating a condition that's being managed by someone else, or literally a condition that you are going to refer to another provider without doing anything about it, will not be counted. So when a reviewer is looking at your documentation come 2023, but this really also comes into play today because they're doing the same thing right now, AMA has just put it in writing, is that they're looking to make sure that each diagnosis, whether it be on your subsequent hospital day or on your nursing facility subsequent day, is each diagnosis that you're putting in your assessment and plan has an actual plan. It shows whether, you know, the status of that condition, what you're doing for that condition, and there's a plan for each of those. If there's not a plan, and you've got to be careful about that copy forward, if that plan is copied forward from a previous visit and there is no changes to it, a payer might actually go, did he really do this, or is this just simply copied forward? So those are things you're going to need to think about when you're looking at your templates come next year. Now, problems addressed. And I've broken this out for you because it's really one paragraph. So this is the definition for a problem addressed. So a problem is addressed that it is managed, evaluated, treated at the encounter by the physician. Take note, this includes consideration of further testing or treatment that you may elect not to go forward with. So it's going to be really important. Let's just say scenario. You have a patient that maybe their blood sugars are starting to look like they're pre-diabetic or something to that effect. And you have a conversation with a patient where you're thinking about, you really would like to start a medication. And the patient is like, no, I want to try to do this with diet. Please, I don't want to start a medication just yet. Give me a chance to try to control it with my diet. Well, if you've documented that you've discussed this prescription, but due to the patient's wanting to try to control it with diet, and if it's clearly in the documentation you talked about that, well, then you can actually count prescription drug management under risk. The same thing with any diagnostic test that's going to fall into the risk category or even the data category. if you actually discuss it and it's in your documentation and for some reason you don't go forward with it, that discussion is going to count and you'll get those points. Again, notation in the record that someone else is managing a condition and you're not doing anything about it, or that condition isn't affecting your ability, or you haven't documented that that condition isn't affecting your ability to care for that treatment or care for that, then it's not going to count. Referral without evaluation or consideration of treatment is not going to count. And then they added, for the hospital inpatient or observation care, the problem addressed is the problem or the status on that date of the encounter, which may significantly different than on admission. It is the problem that is being managed or co-managed by the reporting physician or qualified QHP and may not be the cause of the admission or continued for the stay. I'm really glad that they added that, because hospital and nursing facility care is so different than an office visit or maybe an outpatient consultation. Problems addressed. So let's look at other definitions. A minimal problem. This comes into play for your new ED codes. They are saying that your low-level service, your 99211 in the office and your 99281 in the ED, typically does not even require the presence of a physician or a QHP. Then there's the definition for a self-limited or minor problem. It's something that runs a definite prescribed course and is transient in nature and likely not to permanently alter health status. Now let's look at low medical decision-making. Again, it's two of these three key components. The only real change to complexity and problems addressed is that they added this last bullet, which is an acute, uncomplicated illness or injury requiring hospital inpatient or observation care. This was directly done, I believe, for the ED, for really truly those acute things that, the patient comes to the ED physician takes care of it, and then they leave. Now let's look at data. This is where things really changed. You'll see now that you have two categories, Category 1 and Category 2. And under this, you must meet one of two categories. So under Category 1, you have review of prior external notes from each unique source, which there are definitions for, the review of results of each unique test, and the ordering of each unique test. So now the provider is going to get credit for each lab test they order, for each radiology test they order, for each medical test they order, or if it's an external, patient brings in records from outside, or you request records from outside and you bring them in, you're going to get credit for those if you state, well, where the records are from and what your takeaway is from those records. Then under low, we also have Category 2, which is an assessment requiring an independent historian, and we'll go over those definitions. So for Category 1, you just have to have two of these things. So you could order two lab tests, you could order a lab test, and you could order a radiology test, or you can just have maybe that independent historian. So it could be the husband that comes in that provides you history that the patient can't provide. Then low risk, of course, low risk of any complications, etc. No examples again. So let's look at some definitions. I think this is probably the most important one, in that a stable illness, and the AMA wanted to be very clear about this, that the word stable does not in and of itself mean that the condition is stable. What they're stating is if you have a condition that is not at treatment goal, and I think about this for your diabetic patients, for your hypertension patients, even for your pain patients, where you have a treatment goal that you are trying to get the patient to. So you've got an A1C that you want to get to a certain level. Even though the patient might be stable, they're improving, but if they're not at that goal, then they're not stable. And the AMA made sure to put that in this definition. So you need to think about that now when you're doing your assessment and plan. Providers use the word stable a lot, but when you think about a patient's treatment goal, they may not be there. So consider the way you use the word stable, and maybe start focusing on using the word patient is not at treatment goal. They are not at the A1C goal I want. Then they're not stable. That is going to put them at a different level on your problems addressed. Then we have a definition for the acute uncomplicated illness or injury requiring hospital inpatient or observation level, which is a new short-term problem with low risk of morbidity for which treatment is required. There's little to no risk of mortality with treatment, and full recovery without functional impairment is expected. The treatment required is delivered in a hospital, inpatient, or observation setting. So, like I said, again, this was added specifically for those ED, trips and maybe those short-term observation hospitalizations. Guidelines for data. Now, this is the one area that is going to be a challenge in the hospital and nursing facility, because when the provider orders a test, the review of that test is included in the order. So on admission, maybe the hospitalist orders, a battery of lab tests, maybe a couple of radiology tests. So then the next day when they come to see the patient and they review those results, they cannot count them. I know, wrap your head around that. The review of a test is included in the order. So that's going to make it difficult for providers literally in the hospital or nursing facility setting. The next day, when you come in to see the patient, you can only count new orders. Then the discussion and management of a test or interpretation with an external physician or other qualified healthcare professional, you can count those as long as you're not going to separately bill for those. So a test is anything that is defined by a CPT code. All right. So if you order a panel is defined by a single code. You cannot break those out. So if you order a panel, that's one test. If you order, a chest x-ray, that's one CPT code, that's a test. For the purpose of data reviewed and analyzed, they clearly state pulse oximetry is not a test, so don't try to count it. Another, again, unique, they describe what unique means. External records are records that come from somebody outside of the hospital. So they're from another healthcare professional, they're from another facility, or they're from another healthcare organization. So in the hospital setting, reviewing records from the hospital from a previous date is not an external review. Same thing with the nursing facility. All right, now we're going to move up to moderate. So for moderate, there's no changes in number and complexity of problems addressed, no changes at all. Now for data, you're going to see a change. They've added another category. So now we have 3 categories. And what you're going to see here is that category 2 is no longer the assessment requiring an independent historian. They've rolled it up under category 1. And now instead of 2 of the following under category 1, you have 3 of the following. Now under category 2, you have independent interpretation of a test. And category 3 is now the discussion of management or test interpretation. So for data, it's going to be one of these 3. So you either have to order 3 things, or you have to review 3 things, or any 3 things out of category 1, or you can do category 2, or you can do category 3. It's just one of 3. Now, risk and complications, you're going to see something new they've added. They've added diagnosis or treatment significantly limited by social determinants of health. Again, you just need 2 of these 3 things to get moderate medical decision making. So let's look at some definitions. So an undiagnosed new problem with uncertain prognosis is a problem where the differential diagnosis represents a condition that is truly likely to result in a high risk of morbidity without treatment. This is important because a lot of times previously, under 95 and 97, this was used quite frequently when the problem really would not represent something of high risk. So we now have a definition for that. Then I wanted to point this out under acute illness with systemic symptoms. Again, this might have been something previously that was used when it maybe shouldn't have been. What they're saying is that in this case, if for a systemic general symptom such as fever, body aches, or fatigue, and a minor illness that may be treated to alleviate symptoms, they want you to look at the definition for self-limited or minor problem or acute or uncomplicated illness or injury, because it would be better suited there. It should not be used in the moderate category. All right, so here's our definition of an independent historian. So an individual that is going to be someone that is their parent, it could be a spouse, it could be a witness that provides you history that the patient isn't able to provide you. So in other words, in your record, you're going to have to document who you got the history from and what they told you that is different from the patient that is going to help you provide treatment for this patient. The independent history does not need to be obtained in person, but you have to obtain it directly from the historian. So that is in the definition. So an appropriate source is going to be another professional who are not healthcare professionals. So when I think about this, I think about those behavioral health that you have where maybe you're talking to a teacher, or you might be talking to the counselor at the school. That's going to be your appropriate source. They give the example here of also a lawyer, a parole officer, someone like that. Now let's look at definitions of risk. Social determinants of health right now are so important. You see them everywhere. They're talked about. They have their own little podcasts even about social determinants of health, because it's really the past years have really shown on this, because if someone doesn't have employment and they don't have health insurance and they can't afford their medication, it's going to affect your ability to care for that patient. So you can only use social determinants of health in your documentation if you pull that diagnosis in, and then you state why it's affecting your treatment. So due to the lack of employment and health insurance, they're unable to afford their medications. So then you can use that in the table of risk as moderate. Then they gave us definitions for surgery. This was something that there were a lot of questions about during the 2021 calls with the AMA when they were doing their education. So they went back through technical corrections and revisions, and they added these definitions. The one thing I want to point out about this is that they basically say it is the responsibility of the clinician to determine the risk. And so I provided the definitions for you. Now we're going to go to high. The major difference here is you're going to see in column 1 under problems addressed, altered mental status is no longer there. Well, the reason they removed it is because they felt that it actually could fall into chronic illness with severe exacerbation. It could actually fall in an acute or chronic illness or injury that poses life or threat, or it could actually fall into one of the conditions under the table of moderate risk. It could be in there. So they actually removed it. It's not a bullet any longer. Now, when we get to data, you will see here that instead of one of 3 categories for high, you're going to have to meet 2 of 3 categories. So you're going to have to meet category 1 and category 2, or category 2, category 3. That's what a reviewer is going to look for. They're going to look for either, 3 things from category 1 and then an independent interpretation or an interpretation and a discussion. That is what they're going to be looking for. Now, in column 3, under risk, there are a couple of things. Under decision regarding hospitalization, they added or the escalation of hospital level care. Then the very last bullet, they added, and I always kind of goof up on this word, parenteral controlled substances have now been added to high. Again, 2 of 3 of these categories. The one definition I want to highlight here is the drug therapy requiring intensive monitoring for toxicity. It used to be that a lot of the Medicare contractors had a list of what these drugs were. A lot of them have removed them. I don't believe any of them have a list of them any longer. The AMA has a definition, and they want to be very clear that this is only when the physician is monitoring for toxicity. This is not when a provider is monitoring for a therapeutic effect. They also wanted to be very clear that if you're just simply monitoring by history and exam, that does not qualify. You have to be ordering a laboratory test for monitoring, a physiological test, or even possibly imaging. And they provide the sample, they provide the example of, a provider that is monitoring glucose levels for insulin therapy would be a therapeutic effect. But they did put unless hypoglycemia is current a significant concern. All right, let's jump into what they've done with the code sets. In looking at inpatient and observation services, they actually deleted all of the observation codes. And this was a smart move, and I'm glad they did it because right now when you submit a claim to a payer, you're putting your place of service, and the place of service tells you whether the patient is inpatient or observation. So really, it didn't make sense to have a separate observation code, and honestly, it caused a lot of problems. So now, what you're going to do is you're simply going to use the inpatient codes because they're inpatient and observation both. So as you can see here, we have our initial codes, we have our new time for our initial codes, and we have our medical decision making. So it's one or the other. It doesn't have to be both. Again, in the setting, it is your total time on the date of the encounter. You do not have to worry about counseling and coordination of care anymore. The other thing you'll notice is that there is now a new prolonged care code. We have this 993XO. The new prolonged care code can only be used with the highest level code once the 15 minutes have surpassed. So in order to bill an initial admit, your initial code, prolonged care, you have to go the full 15 minutes past the 75 minutes. So as you can see here for your initial 99223 with the new prolonged care of 993X0, you would need 90 minutes or longer. Same with subsequent. For your 99233, you're going to go the full 15 minutes over the 50 for 65 minutes or more. When not billing on time, you're going to use your medical decision-making table. You're going to do 2 of 3, and here are your levels of the components for you to, acquire or meet in order for your medical decision-making. All right, now let's look at, they did keep the inpatient and observation on the same date. So this, remember, is a calendar date. And I'm also glad that they added this to the guidelines because this is what Medicare expects. And through the guidelines, you'll notice a lot of times that the CMS and AMA worked really closely in developing the guidelines to kind of clear up some of the areas where they disagreed. So in the guidelines, it states these inpatient and observation on the same date require 2 or more encounters on the same date. One of the encounters is the initial admission encounter, and the other encounter is the discharge encounter. So they expect to see that initial documentation and the discharge documentation. Now, they can be completely separate documents, or all of the elements could possibly be included in one document as long as it's clear that these two encounters were done on that date. Now, the other thing they did, they retained the special rules for the codes that if it's less than 8 hours, which this was a CMS rule, if it was less than 8 hours on the stay, then you would use the initial inpatient observation codes, the 99221 through 99223, and you would not use this set of codes. If it was more than 8 but less than 24, or even if 2 dates, use 99234, 99236. That's that's the AMA. Again, these codes also have time. As you can see here, we have our prolonged code, and again, once 15 minutes has surpassed the 85, you would have 100 minutes or more. We have our levels here, so 2 of 3 again, and then I went ahead and put discharge. It did not change. It stayed exactly the same. Office or other outpatient consultations, they removed the confusing language about the transfer of care, and they basically changed it to state services that constitute a transfer of care. In other words, the provider is going to manage the patient's entire care for that condition, are reported with established patient office codes or home visit or resident services. So what they're actually doing is going back to what basically Medicare says, is that a consult is truly a request for an opinion, and then the provider is going to render that service, and then they're going to report back to the requesting provider their opinion on how that patient's care should be managed. It's not when a patient comes in with, possibly, let's say a cardiac patient comes in through the ED and they've had a heart attack, then that is going to be turned over to the cardiologist. That's not necessarily going to be, quote unquote, a consult any longer. Plus, you have to remember that I know this is office, but when we get into inpatient, it changes up a bit. And what they've done on the inpatient side is they've recognized that Medicare does not pay for consultations any longer. So they've removed the term by the admitting physician, and they've put that these codes are to be used by the physician or other QHP for consultations provided to hospital inpatients or observation level patients. So any payer that is using the Medicare code statuses, like in this case, the I, that not valid for Medicare purposes, then you're going to have to follow basically Medicare's rules. Again, we have the time. We have more than 15 minutes for the prolonged, which is 95. And then, of course, we have our levels here. And again, 2 of 3 elements. So it stays the same from code family to code family to code family. Emergency services. Okay, so time is not a factor. So you see no time on this slide. Again, 99281 aligns with the office setting 99211, which is for staff supervision, but we're going to have to watch this one. And this is why. In facilities and organizations where they do not directly employ the physicians, in other words, you might have a group that you have come in that is doing your ED physicians, and they do not employ the ED staff, because there has to be a direct relationship in order for the supervision guidelines. So we're going to have to wait and see if Medicare comes out with any additional guidance on when 99281 can be reported in the ED setting. Again, some would argue these 99281 codes are hardly ever used in the ED. Then in the guidelines, they state that any qualified health professional or QHP can use these codes. They're not just for the ED staff. Also, they say that critical care can be reported with an ED service, and we're going to have to watch for Medicare guidelines to see what they say. So we have our levels, again, 2 of 3. Nursing facility, there are a lot, and I do mean a lot of changes in nursing facility, and I just don't have the time, unfortunately, to go over them all. We could do a separate webinar on nursing facility. But the one thing I wanted to point out, and this is groundbreaking, I feel, for nursing facility, is that they actually, in the guidelines, added a new element for the problems addressed, because they realized the nursing facility, exactly how complicated and time-consuming dealing with these patients can be. So I'm going to go over this. When selecting a level of medical decision-making for the nursing facility, the number and complexity of problems addressed at the encounter is considered. For this determination, a high-level MDM type specific to initial nursing facility care by the principal physician or qualified QHP is recognized. And they've actually given nursing facility its own bullet. Multiple morbidities requiring intensive management, which is a set of conditions, syndromes, or functional impairments that are likely to require frequent medication changes and or other treatment changes or reevaluations. The patient is at significant risk of worsening medical condition or possibly readmission to the hospital. So they even go so far to state that they intentionally left this off the medical decision-making table in column 1, because this is only to be used in the nursing facility. So I put all of the nursing facility code changes on this one table. So you can see the initial with the prolonged code, you can see the subsequent with the prolonged code, and then the discharge. They only deleted one code, and that was the reevaluation. And they basically said that you're going to simply use the appropriate code from 99307 to 99310 for that code. Again, our time-based and our levels 2 of 3. All right, now we have our home or resident service. They deleted the domiciliary rest home, and they merged them all in this category. So now you're going to use the home or resident services for assisted living group homes that are not licensed for those individuals with intellectual disabilities. You're also going to use these for custodial care and residential substance abuse. This code set is now aligned with the CMS rules that are in place. And again, they just simply bulleted it out that do not count travel time, because often providers that are seeing these patients in these settings are having to travel. That time would not be counted. Okay, so here are our home and resident services. Again, we've got our codes, we have our prolonged, we have our 15 minutes that we've surpassed. Then we have, if we're going to use medical decision-making, our 2 of 3. Prolonged services. They did delete the direct face-to-face codes because now we have the shorter 15-minute increment. They did keep the 99358 and 59, and that's because that is going to still be used for services that are other than the date of the encounter. They've basically come out and said that you can use 99417, which is the one they created with the office visit and other outpatient services. You're going to use that with your consultation and your home or other residents, and also the cognitive assessment and care plan. You cannot report 99417 with psychotherapy, so don't try it. The 993X0 is going to be for inpatient observation, consultation, in the inpatient consult and nursing facility. And then there's a difference. For the hospital codes and the codes that were just now released, you have to go past the 15-minute in order to use the prolonged service code. The only difference is that when you're in the office setting and you're using 205 and 215, It's the minimal, and that's why that's in parentheses. Now, of course, CMS, they tried to align, but there were a few places they didn't align. And in that instance, it was prolonged services. So Medicare has come out with 3 new HCPCS G codes. So we have prolonged hospital, inpatient, or observation care. We have prolonged nursing facility, and we have prolonged home or residence. And as you can see by the definitions, there's a lot involved. So what they did was in the, excuse me, in the 2023 proposed physician fee schedule, they provided us with a table, and here's what that table looks at. So if you are going to bill these prolonged codes, you are going to have to be documenting time each time you see the patient in some of these circumstances in order for you to be able to calculate the time appropriately. Because as you can see here, the time spans days. So if you're in inpatient obs, same day admission, date within 3 days, date of visit to 3 days after. So if you're going to try to bill on time, you're going to have to wait until 3 days after the patient is seen. And then if you have any documented time in the record after the patient leaves, you're going to have to be able to add those times together. When you look at initial nursing facility and subsequent nursing facility, you have the day before the visit, you have the day of the visit, and you have 3 days after. So the provider is going to have to remember, if you're going to use these codes, to document the time each time they actually get in the patient's record and are doing anything with the patient. And then if those visits are requested by a payer, you're going to have to remember to send the documentation from the day before, the date of the visit, and any documentation that is done those days, 3 days after the visit. And then if you have home or resident services, it goes to 3 days before, the day of, and then 7 days after. So there is a lot involved with these new G codes. And when you're working with providers, you're going to have to take that into consideration, and that they need to make sure that they are documenting time each time they, have an interaction with a patient or with a record or etc. Sorry. Now, your official resource. AMA is your official resource. This information is available right now. I've given you the link to the article that was released on July 7th with the new guidelines in it. And I would recommend that you read that article. It's great. And then there's also the ability to download directly from the article, or I've also provided I've also provided the link that goes directly to the guidelines changes. I'm going to go ahead and turn this over back to Heather, and I want to thank you so much for joining us, and I'm ready for any questions.
Thank you, Angela, for sharing the 2023 Evaluation and Management Guidelines. We do have some questions coming in for you via the chat, so let's go ahead and dive into the first one. Is there any chance they will delay these changes? This person doesn't feel like there's enough time to educate providers on all of the changes.
Well, I would like to say yes, they will, but that unfortunately the answer is no, they won't. When the 2021 Office E&M guideline changes came out, they actually released them 13 months early to give everyone 2020 the year to educate. But even with the pandemic happening, because the guidelines were already released and they were already in CPT ready for release, they did not delay them. So it was a learning curve, but we got through it. But I think what we've learned currently with working with, physicians in the office setting, those lessons learned, we'll really be able to apply that to working with our other providers in the hospital and nursing facility setting. And the one thing I want to share with the person asking this question is, in order to work with your physicians now and get them ready, just help them focus on their medical decision making and help them focus on their templates and really beefing up their assessment and plan for each of those conditions. And if we can start doing that right now, it'll make that transition come January 1 a lot easier. Thank you.
Great question and great feedback. Okay, next question. If the level of service is based on time, how does the MDM need to support the time?
Oh, okay. So come 2023, it's one or the other, it's not both. So you don't have to necessarily have the medical decision making align up with the time that you're using. However, let me state this. Medical necessity will need to be met. Medical necessity and medical decision making are not the same thing. Sometimes they can go in hand in hand, but there are other times that they don't. And I think people get confused that medical necessity and medical decision making are the exact same thing. So what I'm saying is, if you're spending an inordinate amount of time, or if you're documenting an inordinate amount of time and your documentation doesn't reflect that time. So in other words, maybe the patient came in for something completely straightforward. There wasn't a lot of things ordered. There's no documentation of like counseling. There's no documentation of, maybe a social determinant. There's no documentation that supports really why you spent 2 hours with a patient. Then medical necessity is going to be called into question. Why did you need to spend 2 hours? So the documentation is going to have to support, from a medical necessity standpoint, why you were spending that much time with the patient. So it's not really medical decision making that needs to align. Your medical necessity really needs to be supported by that documentation. Thank you.
That's great. Okay, well, we want to thank you again for attending this webinar on the 2023 Evaluation and Management Guidelines. And thank you, Angela, for presenting and providing us with such great knowledge. Be on the lookout for our email with your CEU certificate and question and answer, and as well as your presentation handout and emails on future webinars. This concludes our session today. I hope you have a great rest of your day.